Bismillahirrahmanirrahim. Today we will have case quiz number 40. Case data: 23 years old female, single with no special habits, right-handed with regular menses, complaining of joint swelling, chronic joint swelling with pain and limitation of movement of the left knee, right knee, and right elbow in this additive manner. So first left knee, followed by right knee and right elbow. This was of intermittent course for 13 years duration, so the condition started when she was only 10 years old. The condition has 13 years duration. The onset was not associated with fever. There is no history of mucocutaneous manifestations, no history of GIT, eye, urinary, or cardiac symptoms, no history of back pain, or history suggestive of enthesiopathy. On examination, she had limping gait, synovitis of the right elbow and the bilateral knee with moderate effusion at the right knee and mild effusion at the left knee. Right median and bilateral common peroneal neuropathy. By investigations, she had ESR elevated 45 mm first hour. CBC was normal apart from mild anemia. The hemoglobin was 11 gram per deciliter. Rheumatoid factor negative, anti-CCP negative, ANA by immunofluorescence positive with a titer of only 1/40, so borderline positivity of ANA. Plain X-ray of both knees on standing, both posterior, anterior, and lateral views show mild osteoarthritic changes on the right knee. Aspiration of the right knee revealed 8 cm of blood-tinged synovial fluid. It was turbid and watery in consistency. The aspirated amount was not going with the degree of effusion. The effusion was very huge, or moderate, but the amount which could be aspirated was only 8 centimeters. We expected to aspirate more than this. So, what is the diagnosis? The answer is yes. You can stop here to search for the answer because it is not common. It is a very rare syndrome. It is pigmented villonodular synovitis, which is abbreviated as PVNS. What is pigmented villonodular synovitis? PVNS, first described by Jaffe and colleagues in 1941, is a rare inflammatory granulomatous condition. This disorder can be considered as a benign tumor of the synovium located at the lining of the joint bursa tendon sheath and anywhere. Regardless of its benign histological characteristic, it sometimes displays an aggressive invasion to the tissues, namely adjacent bone and cartilage if left untreated. The etiology of this case is unknown. Genetic predisposition, chronic inflammation, and even vascular trauma have been postulated. Trisomy 7 and 5 have been strongly linked as a predisposing factor. The incidence is as we said before, it is very rare. It is reported only as 1 to 2 cases per million cases per year in the United States. United States have around 300 million population. So this case is diagnosed only in around a few hundreds of cases all over the United States. The age, young adults with a bimodal presentation in the third and fourth decades. There is no preference regarding gender. Male and female are equal. Regarding the diagnostic studies, aspiration will render hemoarthrosis in more than 60% of patients, but usually it is still normal for standard laboratory testing, which increases the delay in the diagnosis. It is often difficult to differentiate from trauma, hemophilia, giant cell tumors of the tendon sheaths, GCTTS, and other sarcomas. X-ray studies occasionally show a periarticular mass with no other changes initially. Ultrasound have failed to yield a specific image for this pathology, and magnetic resonance imaging, especially T2 weighted image, helps when there is a heavy deposition of hemosiderin inside the nodules. The treatment is resection of the synovium by means of arthroscopy is useful. Open arthrotomy is advisable, requiring in most cases adjuvant treatment with radiotherapy. Extensive bone destruction can necessitate joint reconstruction. Cryosurgery directed to the synovial layers, avoiding that cartilage, have been reported also as a curative with no recurrence. Tumor necrosis factor alpha blockade for the resistant and refractory BVNS have been reported with good results at long-term follow-up. However, the case have many complications. The most common complication is recurrence. Recurrence is higher when simple synovectomy is used, and especially in the diffuse type. Contamination of the portals used in arthroscopy on patients with BVNS may lead to spreading of the pathology into subcutaneous tissues also. The sequelae of this case may lead to joint destruction and subsequent limitation, and more risky, the case may develop malignant transformation, especially with association with trisomy 5 and 7, which we said before they are blamed as predisposing factors for BVNS. And to take a home message, we can say, although the most common cases of pigmented venular synovitis are presented with polyarticular involvement and even soft tissue such as bursa involvement, but BVNS may be polyarticular in some rare cases. Synovial hypertrophy should be suspected if the amount of aspiration doesn't go with the degree of effusion. And finally, thank you for your attendance, and we will meet tomorrow for the case quiz number 41. Wassalamu alaikum wa rahmatullahi wa barakatuh.